Patients with kidney disease are at a significant risk of developing ischemic heart disease. This risk may be reduced after renal transplantation, however, it remains significantly higher compared to general population. Data from previous studies have shown that patients with renal transplant have significantly higher risk of developing adverse cardiovascular event. For example, almost 1 in 10 patients suffer from acute myocardial infarction within the first 3 years. We have studied the outcomes of patients undergoing percutaneous coronary intervention for stable angina or acute myocardial infarction in a national database and show that these patients have much worse outcomes compared to general population. My name is Dr. Rashid. I am one of the clinical lecturers in academic cardiology at Keele University, and I'm delighted to share the findings of our upcoming paper, which is going to be published in Mayo Clinic Proceedings. It's titled as Outcomes of Percutaneous Coronary Intervention in Renal Transplant Recipient, a binational collaborative analysis. This epidemiological study utilizes 2 national databases from United Kingdom and United States. From United Kingdom, we have used the national PCI registry called British Coronary Intervention Society Database, which is a national registry collecting procedural information and clinical profile of almost every single PCI performed in the UK. From United States, we have used National In-Hospitalization Database called National Inpatient Sample, which collects very detailed and granular information about clinical and comorbidity status of all patients hospitalized in the United States. And I'm delighted to be joined by my colleague and co-author, Dr. Nagaraja, who will discuss the results of this study.
I'm Dr. Nagaraja. I'm an interventional fellow at the Cleveland Clinic. It's my pleasure to show you an overview of the findings, and I'd like to thank Mayo Clinic Proceedings to give us a platform to do so. The overall incidence of PCI in renal transplant patients was around 0.2 to 0.3% over nearly a decade worth of patients. Renal transplant patients were younger, with a higher prevalence of congestive heart failure, hypertension, peripheral vascular disease, and diabetes when compared to non-renal transplant cohort. This gives us an impression that the complexity of disease is substantially higher in patients with renal transplantation. However, it's also interesting to see, despite the complexity of disease, IVUS use was only limited to about 5% of the population. The use of glycoprotein 2B3A inhibitors, newer antiplatelets like ticagrelor and prasugrel were far lower in patients with renal transplants. In our adjusted analyses, the renal transplant patients had an increased odds of in-hospital mortality, which was ranging between 1.9 in the NIS cohort and 1.6 as an odds ratio in the PCIS cohort, when you compare these patients to the general population. But there was no difference in vascular or bleeding events. Another interesting finding of our study was the use of radial access consistently improved outcomes in patients with renal transplant recipients. Now, how does this finding correlate to clinical practice? We know that renal transplant recipients have been on dialysis in the past and have a long-standing history of hypertension and diabetes. This results in complex calcific coronary artery disease, and we know that we need to perform further plaque modification and at times atherectomy prior to stent implantation. And no wonder the outcomes are worse in these patients. These findings correlate to our day-to-day clinical practice, and we, as the author group, strongly believe that renal transplant recipients need good pre-procedural planning. This includes access sites. Now, access sites can be quite challenging in renal transplant recipients, given the fact that higher incidence of peripheral vascular disease and previous AV fistula. And sometimes radial access is probably not an option in these patients. The other aspect that I cannot stress enough on is to preserve residual renal function in patients with renal transplant. In this arena, we should tend to use IVUS more often, and contrast OCT is not an attractive option in these individuals. IVUS as we mentioned before, needs further widespread adoption, and this would definitely improve PC outcomes in calcific coronary artery disease. We also believe that IVUS would provide adequate information to the interventional cardiologist to prepare the lesion better with atherectomy, which include balloons or devices, prior to stent implantation. And we strongly believe that these outcomes will improve with more widespread adoption of IVUS. Now I'd like to hand it back to Dr. Rashid to conclude the interview. Thank you.
Thank you, Dr. Nagaraja. That was very detailed discussion about the results of the study. I would like to thank Mayo Clinic Proceeding, and I think this article will bring important epidemiological information about this high-risk cohort, and the readership of Mayo Clinic will benefit from this data in terms of better procedure planning, better access planning, and improve pharmacology of these patients to improve their improve their in-hospital outcomes. It will also help the scientific community in designing further studies in this high-risk cohort, and perhaps a longer-term follow-up will provide more important information about this understudied population.
I hope this helps us navigate the PCI procedural planning for renal transplant patients. We strongly believe as an author group that there's a lot to improve in these patients, especially they're such a high risk cohort. And we envision with future practices that their outcomes would improve. In the next couple of weeks, the article should be available in PubMed as well as on the Mayo Clinic Proceeding website. It's already available online on the Science Direct website. Feel free to contact us if you have any questions or concerns about this study. Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.